Well, thank you for attending tonight. I'm going to tell you a quick story. So, this is not the picture of Dr. Andrew Norby that I would like to have up there. Privately ask me later, I'll love to show it to you. Dr. Andrew Norby will be joining our practice in July this year. Andrew, real quickly, just stand up and give a quick wave here, please, for me. Thank you guys. Hey, everybody. Andrew's at the University of Washington now. And, you know, for Kevin and I, it's a real full circle moment. In 2007, it was still me. Michelle Day was my longtime treatment coordinator. I had not yet hired Kirsten, our first hygienist. Sharice Wagner was our assistant. There was just 4 of us at the time. And I got a call from Mark Norton, Andrew's father. And Mark called me and said, Tom, I am a little frustrated with a periodontics implant that I'm working with. And I'll say his name because it's kind of tied in. His name is Eric Brockman. And I have a colleague that I referred to him for a connective tissue graft. And could you tell me what you charge for that? Showed his patient a great result. So Mark referred that patient over to the pilot. And since that time, Mark has really been one of our absolute strongest referrals. And the full circle moment for me is when Andrew and Luke and Matthew and Mark's kids who are interested in dentistry all kind of came through our practice. One of them finally decided to go to Perio. And Mark's longtime hygienist, Susan Franklin's here. I've treated Susan's parents, and you know, this is just kind of the power of how a network grows, right? So this morning, I texted Tony, and I said, Tony, what's the head count for tonight's study club? Because it's not good to see. I said, Kevin, Dr. Kevin Suzuki is going to be speaking tonight, and we have 6 people coming. I was like, does that include us? And so we got on the phone, and it was really great to have a nice turnout tonight for Dr. Suzuki, my partner. And so please welcome Dr. Kevin.
Thank you. All right, thank you for coming this evening. I appreciate all of you here. I know it's summertime and it's actually a holiday today, so for those that made it, thank you very much. Just wanted to let you guys know, according to Panda Express, you will touch the hearts of many. So I don't know if my presentation will do that, but I will do my best. Oh, we're playing the game there. I don't think PR would be happy with that. Oh wait, you're the PR person. So. Anyway, thank you all for coming and spending some time with us. I did want to present to you a little bit about bone augmentation and implant therapy options tonight. Just a couple of disclosures. I do work on part-time affiliate faculty at Temple and at University of Washington. So theoretically, I'm supposed to say that my opinions don't necessarily represent those institutions. I do need to make sure that I read this legal disclaimer to you. Basically, the information I present represents personal opinion. You know, apply it and use it however you will. Just make sure you do so at your own peril. So I won't read the whole thing, but that's usually what I show, okay? I do have to disclose these are sponsors that I work with or I'm a key opinion leaders for, so just to make sure you're aware of that. And then when I was putting this presentation together, I actually had worked quite a bit with Chad. He was our lead hygienist and does a lot of our hygiene outreach and a lot of our triaging in our practice. So sometimes when I give this to hygiene and general colleagues, a couple of things he pointed out and said, you know, it might be good if you address these questions when you talk about implants and bone grafting. And so one was how to start a conversation about implant replacement with a patient. So I'll give you at least a couple of key concepts that might be helpful. But just in general, really just know about what are the options they have and what are the consequences and benefits of each option. In addition to that, what does it take to set up a site for implant success? I'll give you the answer up front. It's really the amount of bone we have and the amount of spacing we have are some of the most important things. What imaging is used to identify a plan for implants? Well, CT scans are our standard of care that we do in our office and are becoming very commonplace now. And then what is considered a healthy around implants? If we have time at the end, I'll address this a little bit more as well. But essentially, I was just going to give you the updated parameters for implant health versus implantitis. If you want more information about this, I've taken quite a bit from the textbook I've worked on with the Mish and now Resnick Implant Institute. A lot of our faculty have put together this textbook over the last several years of our career. My father and I, Dr. John Suzuki up here, we're currently working on the next edition of this textbook. But they specifically worked on these chapters of bone grafting, And so some of these concepts will come from there. In terms of starting a conversation with a patient, I'm sure all of you have your own ways of doing that and your own knowledge and experiences that you bring and a wealth of options when you're talking to patients. But at least one of the ways that I like to go about doing it is I just tell them, here's the 3 options we have. We've got the bridge, we've got the partial denture, we've got the dental implant. They all have their own pluses and minuses. From left to right, this is kind of the level of invasiveness and hierarchy of cost. Essentially in dental school, I don't remember them emphasizing very much the fact that you will get bone loss and really aggressive and advanced resorption a lot of times with especially this option here. And that wasn't stressed very much when I was in dental school back in 2004, 2005, especially with oral surgery rotation. They just said, get the tooth out. I remember back then they talked to us about kind of pushing the buccal plate back with your finger, and I think, well, that means, you're breaking it and you're actually causing trauma when you do an extraction. So what's the consequence of that? We know that with bridges, in a lot of the prosthetic literature, about 1 in 3 bridges tends to fail within about 10 to 12 years. And so I tell patients the 33% failure rate is not always the best option to put that up front. And success rates of implants we've historically quoted as like 95% and higher, but from some of my other lectures I've given to this club before about implant disease, we are seeing there are some trade-offs that come with that. The risk of peri-implant disease is, in some reports, up to about 30, 40, sometimes even 50%. So everything has its pros and cons. But a couple of things to think about there is, generally speaking, the implant is generally designed to last a lifetime as long as they take good care of it, and that's the first and foremost emphasis we tell patients. So what are the consequences of losing a tooth? Well, if we break it down to some of the most literal things here, it's resorption and atrophy, right? Other things we look at are drifting, right? Loss of occlusal space or crown height restorative space there. Typically, if you want to really get into the numbers, we need at least a minimum of about anywhere from 5 to ideally 8 millimeters of space if you're just doing a single implant. The other thing we worry about is malpositioning, drifting, things like this, right? Sometimes patients come to us and it's already too late. They need to have an orthodontic consultation, or you have to remove more teeth in order to figure out where you're going to put an implant there. So generally speaking, you want a distance of about 7 millimeters for an implant if you really want to get into the parameters there. And this is the ultimate consequence that we kind of fear as surgeons, really severe bone atrophy, right? When the ridge is so thin that you don't have enough bone to place an implant. I'll show you a couple of scenarios of why that's so relevant and why it's important. And I'm not going to go real deep into the numbers as I present this. I'll put them up on the screen. I just have them there specifically if any of you are interested as you talk about implant and treatment planning with your patients. And if, of course, you just want to be like, hey, you should really go see the surgeon, let them tell you all about it, that's also fine. Does anybody know where this character's from? Anybody see this movie a long time ago? Nobody remember? It was actually an M. Night Shyamalan movie, right? So some of you might remember there was a movie called Lady in the Water. And the reason I wanted to show this is when I saw this movie, I'm not supposed to be drama and horror, I laughed so hard when I saw this character because he was a one-sided bodybuilder. He only worked out half of his body. He was actually the super at a motel. And so he let the other side completely atrophy. So anyway, I want to show this to prove the point about bone and muscle atrophy. If it's not used, it's not stimulated, it goes away. And that's relevant to us because these are the types of cases we just kind of fear when we see these patients in our office say, hey doc, can I get that implant now? I've been waiting years for this. I had this tooth out 20 years ago. Nobody ever talked to them about a bone graft, or if they did, they don't remember, right? And so as you might imagine, to attempt to rehabilitate bone back here can be very difficult. Thanks, Tom. Because it's posterior and the maxilla, there's probably some sinus issues going on as well. That's not my focus for tonight, maybe next time. But you can see here just from that radiograph, I mean, how many people are excited about the idea of an implant there, right? So there's at least 2 or 3 steps we have to go through before an implant can even be placed there. And so we're trying to avoid these types of scenarios. All of my slides are based on literature and research. This is the only one I'm actually going to quote very specifically, but this was a study by E.S. Sella. The thing I want you to take away from this is that when you extract a tooth, typically within the first 3 months, the majority of patients, not all, but most, will lose about 1/3 of the buccal lingual or buccal palatal dimension of bone within the first 3 months. So think about that for a second, right? If we don't do anything right away, we lose a lot of the dimension that's there. If you let them go on for up to a year, most patients will lose up to about 50% of that buccal lingual dimension. And the problem is the longer they go, the harder it is to rehabilitate that back. The more invasive it is, the more money, the more time, the more energy. And the scary thing about this study really was that even the most experienced surgeons weren't always able to predictably guess which patients were going to lose bone and which weren't, right? A thick buccal plate doesn't always promise that the bone's going to stay there. And so that was something that I just thought was very impactful. And, you know, again, these are scenarios that kind of keep us up at night. How are we going to grow the bone back? How do we rehabilitate this kind of scenario? So this is a sketch that sometimes I'll show patients when starting the conversation. What is the consequence of losing a tooth? Now, of course, it's a really exaggerated artist sketch. If they lose all the teeth, right, the bone loss can get pretty significant. The thing they don't always realize is there's also an aesthetic compromise over time. Their cheek doesn't have its cosmetic or functional support, right? So they tend to look older, they lose facial dimension and profile. A lot of prosthetic principles really spend a lot of time talking about loss of facial dimension from the chin to the nose. And as it progresses over time, it gets even more difficult to try to rehabilitate. And sometimes it's impossible to get any of that bone to come back. And so sometimes showing patients pictures like these saying, what is the consequence of taking a tooth out, right? Whether it's one tooth or all the teeth, it does set them up for a downward trajectory or a downward cascade. If we were to look at just a cartoon sketch of the jawbone, when a tooth is removed, this is typically the pattern of loss from left to right. Here's the mandible here. If we were to look at a cross-section of the bone, here's the maxilla from left to right over years of time. First, we start losing dimension of buccal lingual. Then we start losing height dimension. And so when we get over to these scenarios here, imagine what a treatment plan for an implant could look like. This is very ideal. Then we start to compromise and need to decide, do we grow bone back? Maybe we start cutting bone away. Maybe we have to compromise the size of the implant we place, right? And just for comparison, in these really extreme examples, there's no way I'd put implants of that size and bone that small. The more bone you lose, the shorter the implants you place, the larger the stress and the off-axis forces. And so it does get complicated over time. In addition to that, the more height you lose, the bigger you have to make the restoration, right? And the longer and the higher you make it, the more of a cantilever force we have. And so, you know, it's more predictable if you have really ideal support in these scenarios here. Once you start getting over to these scenarios, right, it's, you know, on the East Coast, when I went to school over there, they used to call these party gums, right? When you put ceramic on these prosthetics and you have to kind of hide it. Patients aren't always excited about what that looks like, but also at other times they don't have any other option. So ultimately, that's some of the scenarios we look at these. They're called FP or fixed prosthesis categories. Again, from left to right, as you lose more bone, then you start having to make the restorations bigger and longer, and eventually you have to replace some of the bone and soft tissues with restorative material. So that's just some examples of what some of those cases progress over time. These are a lot of the things that we look at. I'm not going to go through each of these in great detail, but when we plan an implant case, of course we have to think about what type of prosthesis. Is it a single unit or is it a full arch? What type of force factors do they have, meaning do they have heavy traumatic occlusion, bruxism? You don't treatment plan a 300-pound linebacker the same way that you treatment plan an 80-year-old grandmother, right? Sometimes you have to add more implants or more surface area. In addition to that, you want to look at their things like metabolic bone disease. Right? How many people think an implant placed here in this type of bone responds the same as an implant in this type of bone here? Right? This is the reason why we have special clauses on our consent forms about bone disorders like osteoporosis and bisphosphonates. Right? And that's a whole other lecture. If we look at other scenarios, you know, how many implants do we need to place? Do we have to treatment plan appropriately so that we over-engineer the prosthesis? And what's the available bone look like? Right? We do have varying sizes of implants, varying diameters and lengths to correspond with surface areas of the teeth that we're replacing. With a molar, you're going to put a much larger implant. If it's a small anterior central incisor, it's going to be much smaller. But as I alluded to, really the thing we worry about a lot as surgeons is how can we build the bone back, or can we build enough? So again, here's a couple other things. If you want to look at the numbers, you don't have to pay so much attention to that. That's why I kind of have those whited out. But really, we look at just kind of the space between teeth. We look at the buccal lingual dimension of the bone. We look at the trajectory of how it's going to come out of the bone and out of the occlusal table of your final restoration. Right? So we look at all these dimensions, the anatomical situations of where the nerve is, undercuts. We have to make sure we place it deep enough so we give you a good restorative room for your restorations, for those of you that partner with us. We have to make sure we have enough of this crown height or restorative space, right? My prosthetic director at Temple once told me when you're treatment planning, scenarios like this, you only have two options. If you want to do an implant, you can either move the teeth back, or if that's impossible, you have to take them out, right? And so think about the fact that these are really hard to intrude. So oftentimes it makes more sense to take them out and just start over and rebuild everything in a posterior site like that. And then people don't always think of this so much when they go to bone grafting lectures, but it's also very relevant. What's the angulation or the trajectory of the shape of the jawbone, right? Sometimes it comes out at an angle. If you want those picture perfect numbers here, you're welcome to take a photo of that. If you ever want me to send these to you, you're welcome to. I kind of like to introduce these just for speaking purposes. When you talk to a patient, they say, you know, doc, do I have enough room for the implant? Do you think one will fit? If you want to undertake that pattern of discussion with them, these are typically some of the dimensions we like to look for. You don't have to memorize these for tonight's lecture, but essentially we like at least about 1 to 1.5 millimeters of bone on the buccal and the lingual. We like to have enough space so that it's not going to cause resorption of the papilla or bone or the adjacent root of a tooth. And so how do we prevent this from happening? Well, really right at the outset, and Tom's always been a really big proponent of this, you never have as good a chance to rehabilitate a site than you will when the tooth is first removed. So you have the best chance when you take the tooth out. And the answer to that and the preservation of the dimensions is really ridge augmentation, right? What that means is you place the bone graft, you're going to get the best chance for success right when you remove the tooth. So I would propose for your consideration to at least consider it maybe a minimum standard of care to suggest the idea of a bone graft if you take teeth out in your practice. Patients don't have to say yes, but when they know the consequences of the bone loss and that it's much more invasive and expensive later on to try to grow it back, it really makes sense to try and do it right at the beginning, okay? So what we call ridge augmentation. And again, the whole premise is to avoid these scenarios here. If we can rehabilitate and grow it back, you have a much better situation of implant and bone support. We're not allowed to do human histology on these types of scenarios anymore, but if we were, what we'd like to see is really healthy, dense bone all the way up along the sides of the implant and the threads, right? That's how we get the best support, the best predictability. We'll just jump into one case showing you an example here. This is a common case. This is actually a family member of somebody that we work with quite a bit. And you can see we could spend a treatment planning seminar talking about what to do with these scenarios here, right? There's periapical pathosis on this one tooth here, but they're periodontally involved. There was some mobility there, right? The problem is this wasn't very predictable to treat endodontically. There was a crack that was present as well and a very deep defect on the lingual. And so if we just take this one tooth out, do we try to just get one implant back in there? And if so, is it going to be pushing up against the adjacent teeth because that space is so minimal? Right? And so we had to make the hard decision, well, it's actually better because they're periodontally compromised to take all 4 of these teeth out and then consider an appropriate prosthetic. So, you know, of course we can open that up for debate and consideration of alternatives, but that was the route we chose and the patient was satisfied with in this case. So just showing an example here. By the way, I know you're eating dinner. If some of you don't want to look at surgery slides, I won't be offended. Feel free to look away for some of these if you would prefer. But here's a typical example of some of the surgeries that we do, right? When we reflect the flap, we try to access the teeth. We like to try and extract them very cleanly, making sure we don't compromise any of the buccal or lingual plate if possible. We'll typically clean everything out. There's various ways to degranulate and clean the tissue out. And then we'll place our regenerative bone grafts here. Right? We typically use a human-derived bone graft. We can also use bone we harvest from other parts. There's also synthetic and animal-derived bone, which I'll talk about very briefly. We typically like to add things like antibiotics or sterile saline, place them in the area, and in this particular case, I didn't feel like it was a good immediate implant placement scenario because the bone was just so compromised. And so we tried to rehabilitate and grow back a really ideal, robust dimension of bone first. There's what the x-ray looks like after grafting. You can see when she came back after about 4.5 months, we have a really thick ridge, at least what we can see visually on the outside. We ended up taking a CT scan. We'll often use surgical guides in complex cases like this with multiple units. You can see this is what our kind of osteotomies look like here. Try to make sure that they're perfectly parallel. This is just another example of showing some of the drills there. Again, keeping our parallelism. You can see with the dimensions of the bone here, we at least have that 1.5 millimeters of buccal plate there. Nothing is showing through, there's no undercuts. And then we placed implants. There's the x-ray. I actually chose to do a delayed approach in this case. Let them heal for a couple of months. We went back to uncover the case, put some healing abutments on there. You can tell this is an older case now because, you know, Tom and his infinite wisdom has really pushed for all of our team members now to do custom healing abutments. How many of you have had a lunch and learn from us before? Can I see a show of hands? Anybody? A couple of you. So one of the things that we like to show is that that is our new push now, is really to make it easy for you to restore the cases, and we do that by placing custom healing abutments. So, and the reason for that is we don't want you to struggle when you go back to place the crown and you're trying to force it down, the tissue doesn't quite match up. So that's one of the things, if you want to talk more about that with any of us at the end of the night, feel free. But that's a typical case where we preserve the ridge, very predictable, they have a nice outcome. And we borrow some of these principles from periodontal disease. This was actually a principle we borrowed when we used to have defects around teeth. We still do this, but it's called guided tissue regeneration. The idea is if you clean out a defect, especially if you have walls of bone with a good blood supply, you can clean this area out. If you just allow the tissue to grow back without doing anything else, the tissue or the epithelium always grows back in and will win the race between healing when it comes to either bone or soft tissue. And so we call it tissue invasion, or at least that's a concept, if you don't exclude this area and actually create an opportunity to grow back. And so the idea is we would use these occlusive barriers. They're called guided tissue regeneration barriers that we would place in the area. After you clean it out, then you put the tissue over top, and over time, what we actually saw was the bone would grow back, the periodontal ligament would redeposit around the tooth. We'd even get cementum that grows back on these teeth for these types of defects. And so if we can harness the body's regenerative potential, we really have the opportunity to also grow back bone for edentulous areas, for implant sites. And so we borrow this principle of guided tissue regeneration with these various barriers that we have. If you want to know more detail about this, I can talk with you after, but essentially we have a couple different types that resorb and that do not resorb. And so depending on the various parameters of the defects, we'll make a decision and recommend certain types of these materials here. Sometimes you have to go back in and remove them if they're non-resorbing. If they're resorbing, you can just leave them in and the body breaks them down naturally. Here's a couple other examples just showing you some principles of kind of various defects that we can create. You know, even if they're very severe like this, we have various options and ways to be able to reconstruct that and sculpt it back. Some of you have had the privilege to work with Dr. Liu before. He's got these really great technologies of these, meshes that have support, and a lot of us are trained in doing these on a regular basis. There's also various titanium and, reconstructive skilled kits like this. I think Dr. Cha does some of these, right? You do some meshes? Not so much? Okay. Well, she's very skilled with these. I know she used to. She used to in residency. So, yeah, Alan and Jen are very skilled at using these here. Okay. So in terms of bone grafts, what's important for you to know about that? If you're interested, here's the various categories I'll show you here on the next slide. There's basically 4 categories there. And sorry, the color doesn't show up quite the same on this as it does on my computer. But we have 4 categories. One is you can take bone from the same person. We call it an autograft. You can take an allograft, which is bone that comes from a different person of the same species. You can take bone from an animal source, right? So we have FDA approval of a cow, a pig, or a horse right now to take bone from those. Or we have synthetic materials called alloplast. And on this graft here, what I was hoping you could see, it's in white, but there's an arrow from top to bottom because that's typically the order of preference. Autograft is usually the most potent regenerative potential. Then comes the allograft and then other species, and the synthetic is kind of our least preferred for implants because it takes a long time to turn over. Okay, and it's also important to have options because some patients have certain personal, cultural, or religious convictions where they don't want certain types of materials in their body. So we have to have options to borrow from. I was just going to show you a video here. This is actually from a workshop I taught at the Florida Dental Association last year on bone grafting. Of course, it's on a typodont, but there's various ways that we could harvest autograft or bone from the same person. Sometimes we can go to sources like the ascending ramus and the mandible. There's older techniques where you could actually take from the symphysis to the chin. You can really take from anywhere you can access that's not going to cause bone loss around another tooth. So this is just showing one technique. It's of course much older and less efficient, but you can take things like a ronger, harvest bone chips like this, various ways to get those types of bone. For the allograft material that comes from a person, they're really nice because they have a great shelf life. They're fairly low cost, right? They're very easy. You don't have to harvest it from somewhere else. This is usually our go-to most of the time now. And what I'm showing you here is just the idea of a tooth that's been extracted. The buccal plate's kind of compromised there. And we're placing this particulate graft material in that defect. You can see I've got a barrier membrane lined up. We're going to reconstruct and kind of build. And the idea is you want to fill and really enhance the dimension of the bone that you have there, right? You want to get a nice, robust foundation. Then if you have really ideal dimensions, you can put the implants in no problem. Again, not necessarily a case where we want to do an immediate placement because there's hardly any bone there to hold on to for primary integration. So that's just the idea, kind of showing you how we go about some of that. A little bit more on the xenografts, so the bone that comes from other species. The FDA has currently approved cow, pig, and horse derived forms of bone. If you look at the micrografts of these, they're somewhat similar to human bone, but they're processed and sterilized so that they're very safe to use. They've removed all the immunologic aspects that might cause a problem otherwise. And so we can borrow these. The one criticism that a lot of surgeons have is these take a lot longer to turn over. So imagine doing a bone graft and telling the patient maybe you need to wait a year or a year and a half to get an implant. That's not always going to fly. They want it now. They want it yesterday, right? So these are some of the things just to consider. When I was at Temple, I did my master's research on the synthetic grafts. I kind of voiced a little bit of a preference to use those last or not at all. We went to a primate colony down in Buenos Aires, and we actually did bone block sampling on an ongoing project. They had a colony of about 30 primates. Some of them had lost teeth, and so they had certain types of bone graft materials used, various implants. So we actually compared block sections on an area that had some bone graft with a synthetic material, and then also with human-derived material. So remember, because it's a monkey, it's a different species. This is actually what we call a xenograft because it came from a human into a monkey. So this is typically when we do histology. This is what bone looks like if it's rehabilitated pretty well. You saw the marrow and trabecular spaces are very small. And I promise it's the only histology I'll show you all night. I don't have a lot of these, okay? But the concerning part was the synthetic material. This is what the bone looks like. Does anybody want to guess maybe how long it had been since we did the bone graft in this area here? Maybe 6 months, maybe a year? 4 weeks, right? The actual answer is 4 years, right? This had been placed for 4 years, and a lot of the grafts still hadn't turned over. So that's why I'm not a big fan of synthetic graft materials if you can help it, because imagine having to wait 4 years or more, and you go to put an implant and the bone still isn't ready, right? So that's a couple of things just to think about. So really the principles when we try to think about how we're going to grow bone back is how likely is it to have really good vascularity or good walls of bone, right? When we see a socket like this where the buccal plate's missing, it's less predictable to grow bone back than it is with a perfectly intact socket like this. This is just a diagram from one of our textbooks basically stimulating or showing the principle of bony walls of vascular supply. The more bony walls you have, the more perfect a situation to get vascular structure and cells from all sides to help bone turn over and grow back. So that's why a socket is always the best scenario to try to graft right off the bat. If you wait or the patient waits too long and eventually they start to have resorption and abscesses that destroy the plate like this, or a really traumatic injury, it's less predictable. So, you know, one of the things I'd like to show are scenarios where maybe we've had clinicians in the past that try to push the technique or they try and put that implant in even though they don't quite have enough bone. And I'm not trying to pick on anyone specifically because I've been guilty of this in the past. I know in residency I was trying to get stuff done all the time. But these are the types of scenarios that they come back. This patient's had 2 implants placed, right? When they smile right off the bat, you see this. So how many people are excited about finding what's going there when they do their next maintenance, right? And then they pull the tissue back to take a photograph. You can see gray showing through here. And she was telling me she was thinking about trying to get gum grafting to make this look better. There's no way we're going to get that to work, right? And then if I show you the implant x-rays, how many people want to tackle this, right? We actually thought about attempting LaPip, but the problem was this was already mobile. And so she said, I don't want anything that has a maybe, I want the best guarantee possible. And the problem was I said, well, you know, if I touch this and take this out, this one is going to have to suffer in some way no matter what I do, because once you reflect the tissue, a lot of this is going to collapse and go away. And I said, the only way I can try to possibly reconstruct this is if we take both out, but that's very invasive and I'd rather not do that. So anyway, maybe I'll show this case at some other time, but I think this originally happened because the bony dimensions, the buccal plate, was very thin. They tried to put the implants in originally, immediately at the time of extraction, and there just wasn't enough bone there. And so this is ultimately what one consequence of that can look like over time. They lost bone. You can see when they put the implants in, they'd perforated right through the buccal plate here, right? So these are a nightmare to handle. This is not a case that Tom did, but it's one that he inherited, right? And Tom was very brave in trying to take this on because this patient was referred to him. They were all showing through the tissue. Do you remember this case, Tom?
Yeah.
Yeah. And so, you know, he had inherited this, and they said,
I can place this.
I started with that caveat. I said you didn't place them. But see, we have the tough job sometimes as surgeons to inherit the complications and decide, okay, is it worth trying to grow the bone back, or is it better just to take them out and start over? And so, you know, Tom had kind of used a combination of removing some, and then he eventually grafted some of the others, and he was going to get them rehabilitated to the point where he could place more implants. I don't have the full case here, but he did a really nice job eventually rehabbing it and putting a full prosthetic there. Now, this isn't a case that Alan did either, but it's one that he inherited, right? So you see a little bit of the gray showing through. If you put your finger there, you can actually feel a concavity. You could feel that there were threads of an implant through the tissue. So Alan had the difficult task of trying to figure out how he was going to address this. You reflect the tissue, it looks like that. what are we going to do with that? Do we cut the threads off and graft it? Do we take it out? Again, I think that's because somebody tried to push the technique. When they put the implant in, the bone was too thin. And so, again, I just bring this diagram up to show you, bone resorption is progressive over time. It's never, easier or better to graft than is right at the beginning. And so when we don't have enough bone in some of these scenarios, what are some of the other ways that we could possibly consider a treatment plan then? Well, we could cut bone away. It's called osteoplasty. And so the idea is, if the bone's too thin here, maybe you cut some of it away and then you can use the better bone down here, but it comes at a cost, right? Because everything is taller now. The restorative cantilevers are greater. We could use some of the particulate techniques that I kind of showed you or alluded to in that earlier case. There's more advanced techniques of very large volumes of bone called block grafting, various membrane techniques we have. And then I won't talk about sinus augmentation today, but in the posterior maxilla, that's also a really severe scenario. And so to answer Chad's question for review, what is the imaging we use to identify a plan for implants? Well, the majority of cases we'll use a CT scan, okay? So a scenario like this, I don't know, maybe not a lot of you aren't always looking at scans every day, but we can basically take cross sections of a specific area in the mouth, and that's what we're looking at here. Right? And so when we look at a tooth like this, it's fractured, is referred to us by the endodontist. They say they can't save it, or they just can't rehab it again, or it's not worth it. We're looking at what is the dimension of bone from buccal to lingual, what's the height till we get to the floor of the nose, and that's in a case like this. And so then we have to decide, is it worth it to try and take the tooth out, place an implant immediately? What's the position of the nerve here? So this is a pretty good dimension buccal lingually, 8 millimeters, more than 8. Can often be helpful. So theoretically, that's about how we might place an implant there, more to the palatal for a screw retained restoration. And so, some scenarios, as I mentioned, one of the things we can do is try to cut bone away. So when we have a scenario like this, maybe that was the jawbone shape. You can cut some of the real thin bone away. It's more simplistic. It requires less intervention. Then we have a lot thicker bone here to place an implant. And so that's a scenario where we can do that pretty easily. Again, I promise you I won't go really deep into the numbers, but essentially we can just cut it away to get thicker bone, right? It comes at the cost of making the crown much longer. So there's a scenario there, kind of, from start to finish, what that would look like. So again, there's those party gums again, right? You got to reconstruct that. Now this is a common thing that we'll do for these full arch cases that we'll often work with many of you on. You do actually have to intentionally cut some of the bone down because you do need enough height for the restorative material. If you're doing bar retained, prosthetics, or you have these different copings and things, you do need enough crown height space to be able to do that. So sometimes it is very intentional. Sometimes we can look at particulate techniques, and what that means is, again, the same scenario I just showed you in the illustration. If we don't have enough bone on one side, we want to place an implant here, but we know it's going to be, too thin, or the implant's going to be showing through. We can try and reconstruct it back. And so we can do some of these various techniques I'd mentioned with bone grafts and membranes. We often have to wait a minimum of at least 4 to 6 months for that to heal, depending on how extensive it is. And the success depends on the number of bony walls that are there. If we're trying to gain just width, right, buccal lingual, it's a lot more predictable. If we're trying to gain height, it's a lot more challenging. So there's a couple things to think about. I want to show you an example just to scan here again to orient you. This is the lingual side here. This is the buccal, and this is for this posterior area down here. When you first look at this, the shape of the bone there and the thickness, you think, okay, that's pretty thick. We have about 8 millimeters of bone. We can place an implant there. But then if I show you this picture, you say, well, wait a second, why are we planing it this way? Why would we put it upright like that, or try and change the angulation? Well, the problem is when you look at the opposing arch, here's where the opposing tooth is, right? So if we put it going this way, following the bone, there's no way they're going to be able to occlude the opposing tooth. So these are some of the things also to think about, right? What's the bone angulation? And so when this is my best efforts to try and draw a virtual crown there. But you can see if we put in the ideal restorative position, right, a crown that occludes up here, it's going to be sticking right out the buccal plate there. And so that means we have to rehabilitate or grow bone back. That's one of the best ways we can try and get a good outcome here. So that's just kind of showing you how we think about it. I'll go a step further and just show you that there are various scenarios like this that we encounter every single day in our surgery practice, right? All these are scenarios where if we try to place an implant, what does the bone trajectory and the morphology look like? Here's what it looks like if we attempt to place bone in each of these scenarios. We try to place an implant, where do we have to grow the bone back to get an ideal situation? And so this is basically the answer to the puzzle of various ways that we go about doing that. These are all different kinds of techniques, different kinds of strategies we have to use to grow it back. They all have their own challenges, right? I'll just show you 1 or 2 cases kind of showing it, but this is a common technique a lot of the docs are very familiar with in our practice. It's called tending screws. we basically rehabilitate or grow back sites where the bones really collapse by adding some more support. And so the idea is we'll place these various kind of supports or struts here to hold the bone graft in place. Sometimes if you just put bone in by itself and you let it heal, a lot of it can resorb away quite quickly. And so the idea is we'll reconstruct it, kind of build it up. You want to get this ideal morphology. Here's another kind of cartoon example here showing, again, an implant with not enough bone support. We have to build it out that way. And so you put these screws in there, we'll build it up with bone, rehabilitate it. It's basically kind of like sculpting it back. Let it heal the appropriate amount of time. These screws always get removed or always come out, and then we'll place the implant in an ideal scenario. And so that's the idea of another way that we can reconstruct it. So here's an example of just a very simple case with one site missing. And I'll show you a video here. Now this is a workshop again that I taught in Florida. It's just showing on pig jaws, but I want to show you the idea of when we access an area and clean it out like this, one of the first things we do is we do what's called a corticotomy. Does anybody know why we do this or want to comment on that? Blood supply, right? The idea is you want to get better blood supply to the area, and we do that by puncturing holes intentionally into the bone. They call it the regional acceleratory phenomenon, or the RAP. And the idea behind that, again, is if you want to see the literature, is basically when you just cut holes in the bone, better blood supply, better bone regeneration. This is based on an old study in the 90s that was done on actually rabbit skulls. They took some New Zealand rabbits, they opened up an area of skin on the back of their skull, and they drilled some holes on one side, the other side they didn't, and they put some occlusive domes there. When you look at the histology, the side afterwards where they drilled the holes, the bone came up and almost filled the dome after about 42 days. The other side they call it the controlled, you didn't get very much bone growth there. So that's the principle in case you ever wondered why we cut so many holes in the bone and grow it back. This is just showing an example again from one of the workshops of, if we're going to use this technique, kind of how we place some of these screws. So there's the corticotomy holes there. This is just showing a clinical example, and of course one of my patients. So sometimes they just need one screw, sometimes they need several, depending on how complex the defects are. And then we'll eventually place some type of occlusive barrier membrane, whether it's resorbing, maybe non-resorbing. Sometimes we'll use tacks to do that, sometimes sutures. Jenna Chaw, by the way, is very skilled with her suturing techniques to kind of tent everything down, so she showed me a lot of great work. This is showing examples here of various types of graft materials that we'll use, again, from the workshop. We'll compress the bone around these constructed tents, right, or these tending screws, basically build it back up, and then close everything up there and let it heal for anywhere from 4 to 6 months, depending on how complex it is. And so there's an x-ray we'll typically take afterwards just to kind of check how it's doing. This patient ended up coming back after several months. We took a CT scan. You can see now where the tending screw is placed. We've got plenty of bone here now in terms of width. We want to make sure we're mindful of where that nerve is. Place an ideal size implant. Here's an example of those custom healing abutments that many of you are now used to seeing that get cases back from our office. And then eventually the patient was sent back for the final restoration. So there's the x-ray there. So that's the idea of kind of tending screws there. I'll go through this a little bit more quickly. This is a more complex case. This patient actually had to have the number 7 and 10 extracted because they were failing. And so this is just showing some various cross sections. You don't necessarily have to look at all these, but just to give you an idea, this is only about 4 millimeters across from buccal to lingual. So we try to place our skinniest or narrowest implants 3.5 millimeters in width. Right, for a big support of a bridge like that, it's not going to be very predictable. We need to get more bone there. And so we open everything up, we'll place various screws like this sometimes, or various particulate materials there. Use barrier membranes to basically protect and cover that over, close it up. And then this is what it looked like after a couple weeks of healing. After a couple months, they come back, we'll get a CT scan often. I just kind of showed you, jumping right to the end, we ended up placing 3 implants in a case like this, just because I wanted her to have more support. That was her provisional that she was wearing while she was healing. And then this is the CT scan we took, just to kind of show you what the tending screws had looked like. And then we went on ahead and placed the implants. That's her final restoration with her smile line. So it was a difficult situation to start with, and we were able to get some bone enough to rehabilitate the area back. Here's one of Dr. Chaw's cases. If you want to share anything, let me know. Otherwise, I'll do my best with it. But Jenna had graciously shared this case with me. It actually had a couple of failing teeth, and one of the canine was fractured, and then also I think it was number 9 was failing here. So, she took a CT scan to kind of reevaluate those sites. You can see a really significant periapical disease going on here, starting to compromise the buccal plate. You can see the fracture there. Crown lengthening on this tooth wouldn't be a great idea because after you remove so much bone there, the crown to root ratio is very poor. So, a couple of other perspectives here of this cross section, this scan. This tooth is basically just floating in an abscess there. Do you remember what the mobility was on that? Do you remember the mobility on this tooth, or was there any? Class 3. She probably could have pulled it out with her fingers. And so this is what her surgery looked like. And on the right side here, what I'm showing is one of Dr. Chaw's favorite harvesting instruments. It's called a bone scraper. The idea is you can actually go to other parts of the mouth or adjacent areas, and you just take this little instrument here and just kind of scrape it. It harvests plenty of autogenous, really regenerative potential bone. It's very minimally invasive. Patients don't have much discomfort from this process here. And you see, as we kind of show you what that looks like, it basically harvests the bone and keeps it in a little reservoir. And so you can harvest as much as to fill this whole thing up here. And so you can see the palatal plate was missing, the buccal plate's compromised. Jenna had her work cut out for her. So she wanted to pull out all the stops, use this really, pluripotential regenerative material, and that's the patient's own bone with their own blood. And so she got a really robust amount of bone harvested. You can see really with a master of suturing here, she built it up really robustly, got everything closed up. That's what it looked like in both of the sites that she treated on the same day. Then she was planning for a CT scan for delayed implant placement several months later. You can kind of see here what the cross section looks like. That was a really healthy result she got there. She was, it's about 7, 8, 9 millimeters of bone from buccal to lingual, I think, right? And then on this other side here as well, really robust, really healthy, ideal ridge of bone there. So, the plates were originally missing there. She got really nice results to be able to plan those. She ended up placing the implants, immediate provisional, you said on this one, I think, right? On number 6, she did immediate provisional, and then within a couple of weeks, I think she said the patient fractured the provisional, but the implant was still integrated. So at any rate, things ended up working out really well. When she went back into place the implant here at the number 9 position, really robust bone there. And then you can see kind of from start to finish, here's the implant with the provisional here, there's the delayed placement there. And then that's at least the final result after closing everything up there. Here's what the radiograph looked like with the provisional in place. So again, a really nice job. Anterior cases at really high aesthetic demand, being able to grow those back. So that's 2 weeks post-operative there. There's a year later. And so we've got the provisional. You said again the patient broke the provisional, had to come back. I think they wore it too long, right?
Yeah. The initial provisional, I actually placed it and I cut it in half because he had really deep height. But a year later, his provisional fractured off in the gut.
Yeah, so he
didn't have anything restored yet.
So he didn't restore this for a year.
Something up real quick.
Right. And so what we do is we make sure we put the provisionals, the ones we lab fabricate, especially a lot of you that work with us, we try to make the shade just a little bit off, and it's just a little shorter than the tooth next to it, because we're trying to avoid those scenarios where the patient's like, oh, this temporary is fine, and then they have it for a year or two, and they don't come back to you. So Tom's really great about having that conversation.
It's always good to go.
Yeah, absolutely. This is another example just showing one of Alan's cases, just a really extensive defect here. You can see decorticated and placed a screw there, really built it up with bone and some membranes. This is what it looked like with a resorbing and a non-resorbing barrier. It closed everything up. That's just kind of showing you some of the principles there. I just want to give you a couple different scenarios and kind of how we rehabilitate those. Just checking our time here. When things get quite a bit more extensive, there's other types of kind of advanced techniques that various doctors like to employ, and this isn't the only way to do it. There's various ways to tackle this, but just showing you one case here again, this was a congenitally missing tooth here. The shape of the ridge there was not very favorable, right? The height was pretty good. We had 17 millimeters of height from the nose to the tip of the bone, but when you look at a scenario like this, if we try to put an implant at the ideal position, the ideal size, we're left wanting, right? There's not enough bone there. And so this was just our 3D planning software again with kind of the same scenario. So we know that we have to grow quite a bit of bone on the buccal like this. And so one of the ways that we do that is we can try and harvest bone, a more robust, really kind of aggressive technique where we take a block of bone away from the mandible here. And it's just showing another example from one of my workshops. The idea is we'll create an osteotomy cut in various principles here. We just have to make sure we know where the nerve is so we don't cause any damage. We'll essentially elevate out or harvest that block of bone. We'll drill a hole in it and fixate it right to that area where the bone's missing. So, I probably do about maybe 10 to 12 of these a year. Some of the doctors, maybe not as many. Some doctors have much better results with the mesh. So again, this isn't the only way to do it. This is just one technique. But I just kind of wanted to give you guys a kind of a smorgasbord of all the things that we can do. Right? This is just showing again with the type-it-on example how we typically drill a hole. and then we'll go ahead and fixate it with fixation screws to the defect area. So just an example when you need to get a really large volume of bone, and maybe there's some skepticism on if some of the other techniques might work. So just showing you some examples there. Okay, this is what it looked like after we fixated the bone here. I did place a bunch of particulate graft as well, so it's kind of like a brick and mortar technique to do that. Your kitchen sink, we're kind of adding everything with a membrane, closing it up. When we came back and took the scan 6-7 months later, this is what it looked like. We ended up taking these screws out. This is when we re-enter. You can see the bone is really nicely fused and integrated there. The screws come out, we place the implant with our surgical guide. This is placing the implant there, and then in this particular case, again, this was quite a few years ago. It's before we used custom healing abutments, which is now our standard. And then they went on to a nice final restoration. So I think that was a pretty good result. I think this kid was only about 19 or 20 years old, but he'd been missing this tooth for a very long time. And so there's quite a bit of resorption. Just another example here, kind of showing you a case on the lower mandible. If you look at the cross sections here, the bone is extremely thin. In this particular case here, we were planning for 2 implants. So we had to get quite a bit of dimension and thickness there. So yes, we probably could have done this with tendic screws. Maybe we could have done it with, suturing bone graft and resorbing barriers. In this particular case, we chose to harvest a piece of bone. That's what it looked like from the harvest. I fixated it into that area where the bone was very deficient. This is what the CT scan looked like about 6-7 months later, right? So we got really nice, robust amount of bone there. And then that's typically when we treatment plan the implant, what it'll look like on the scan. Here's when we go back in to remove the screws. We ended up placing 2 implants there, used a surgical guide, and then that's what the final restorations eventually looked like after another few months. So the patient eventually went on to have the same thing done on the other side of the mouth. So just showing you, what the cross sections look like, at least of these implants. So we have at least that 1.5, 2 millimeters of bone, buccal and lingual. It's a little bit thinner here, but we had about 1.5 millimeters there, so I was satisfied with that. And then she ended up having both sides completed. I wanted to show off Dr. Norley's work as well, because he's just joined the practice, but actually I was quite impressed. Andrew sent me several of his cases earlier in the week, and I had forgotten how much you learn in residency and coming right off the bat. You have really great pictures, Andrew, so I want to give you some props. That's okay. Well, I just wanted to, of course, to feature Andrew because he is starting in our Fred Away office and Eastlake, so he's going to be at both locations. Yes, Claire.
All 3.
Oh, all 3, I'm sorry. He'll be at all 3 locations, so everybody wins. Andrew, do you want to share anything about the case? Otherwise, I'll do my best with this one.
Bilaterally impacted canines that they tried to move them, bring them into place, but they were ankylosed, so they ended up extracting them. Left a huge defect. Patient's 27, I think, when he came in. And then he came to me and I was like, oh. So it's a bilateral as well. I don't know if you have both of them, but he's been without canines. Never actually had canines in place. So.
All right. So he had his work cut out for him, right? And so you can see just the evidence of that really resorptive defect here, right? If we try to put an implant, what would be the ideal restorative position, it's going to be sticking outside the buccal plate. If you try to put it too palatal, we're going to have a huge cantilever, a huge restorative defect. It's going to be hard to maintain. So Andrew reflected his flap.
That was the space from the canine. We had to basically make a window, but we wanted to leave the buccal bone intact, so we had more of those bone walls for regeneration.
You see your corticotomy there. You got some wrap holes that are on the side there. And then that's what some of the defect looked like from the other perspective from the palate. Right? He did a really nice, robust job of grafting the area, trying to reconstruct and sculpt that bone. He wanted to build back the buccal plate. Do you remember what kind of bone you used for this?
Just allograft.
The human-derived allograft. It's a really nice suturing with holding the membrane there. Oops, sorry, I went too fast. Here's him kind of trimming the membrane in an ideal scenario to kind of cover over and then close everything up. Let it heal for various months, and then just kind of showing what it looked like upon re-entry there. From the buccal now, you see we no longer have that concavity or defect anymore. And I think I have this mirrored. Sorry about that, I might have got it backwards. Yeah. At any rate, you can see upon re-entry, really nice buccal plate. The graft is nicely integrated. You've got really great buccal lingual dimension there. Placing the implant. And then this is what the final result looked like restored. So I think that was a really nice job. Okay, so just another example of kind of what's possible, especially with these really severe defects. So that's the majority of the grafting material I had. In the last 2 or 3 minutes, I was just going to show you, Chad had mentioned it might be a good idea just to show what does implant health look like versus disease. So I have given an implantitis lecture before to the study club, but it was quite a few years back. In case you're interested in what the new categories and the new criteria is, this is typically what an ideal health scenario looks like. So whenever you see these implants, you restore them. They're in your practice over years. Right, you typically want to make sure that you visually inspect the implant every time they come back for a recall, and they should not have, of course, signs of inflammation, no redness, no bleeding, no swelling, a lack of bleeding on probing, right, because then that's often an indicator that some type of issue or inflammation is going on if it bleeds. You want to have a good baseline probing depth after it's restored, so you have an idea of what that soft tissue crevice looks like, and then check it at least minimum once every year. Right? If you ever have a change in that depth, that means it's a change in some type of health quality or health status. And then you typically want to have no bone loss after the first year. And why do I say that? Because most implant systems will have a little bit of remodeling or crustal physiologic remodeling within the first year. You'll lose a little bit of bone, maybe a millimeter or so down to the first thread. This is what implant mucositis looks like, right? It's the equivalent of a gingivitis around teeth. So we'll typically have redness, swelling. It typically bleeds very easily when you put the probe or introduce a toothbrush to the area. So bleeding on probing, erythema, swelling, sometimes suppuration. But when you take the x-ray, there's no additional bone loss or remodeling there. So the nice thing about this is it is very predictable to treat. Typically non-surgically we can handle this with mechanical debridement. Maybe we use our laser to clean it up. It's very reversible and it goes away quite predictably. Okay? And then the last definition I'll just share with you is, of course, the most updated AAP or periodontal definition of peri-implantitis. These top three are the traditional ones we used to use. We'd look visually to make sure there's no inflammation, bleeding or suppuration. Again, an increase in probing depths is always a sign of concern or something needs to be investigated further. And then radiographically, this progressive bone loss, right? We don't always have the luxury of being able to compare this right from the beginning because a lot of us inherit implants from other offices. Historically, they had it somewhere else. So this bottom half is actually the more practical criteria. When you don't have any initial radiographs or probing depths, they set a threshold of at least 3 millimeters or more of bone loss from the crest. And if you have probing depths of 6 millimeters or more with what they call profuse bleeding. So this is always going to be an indication that some type of surgical intervention is necessary because statistically speaking, non-surgical care almost never works when you get to this implantitis definition. And a lot of you have seen our lectures on LaPip or the laser associated technique that we use, which is very predictable. Jenna's certified in it, Tom's certified, all of us are, and Andrew's going to training I think next month. So that's something that works quite well. So at any rate, I just want to thank you all for being here. I'm sorry I didn't have the other picture of Andrew up there, but if you guys ever have questions, Tony actually has all of our contacts. Tom's always prided our office on being, leaders in the community, on being very accessible, very transparent, and very kind, right? There's no judgment if you come to us with a problem. We just want to be available to support you. If there's something you're like, hey, maybe I messed up or I need help, that's what we're here for. So thank you all for your time and attention today.
Awesome.
Do you have any announcements, Tom?
We are off in July. Are we off in July and August?
Just July.
Okay. We also have invitations to the Barbie Beach Party Luau this year. If you're not on that list, please let Tony know. Make sure to get that invite. Steve Rockwood, I expect you to be fully rocking it. Anyways, see you guys at the luau. Thank you very much.
Thanks, everybody.